You're listening to Who Said, a Cardiology Board Review series. No fluff, just facts.
This episode is about restrictive cardiomyopathies. Restrictive cardiomyopathy refers to any cardiomyopathy characterized by abnormally stiffened ventricular walls that result in impaired diastolic filling of the heart and thus elevated filling pressures and subsequent heart failure symptoms. Unlike dilated cardiomyopathy, where systolic function is usually impaired, restrictive cardiomyopathy typically preserves left ventricular ejection fraction in early stages. At most, it'll be mildly reduced. Systolic function may subsequently become impaired in advanced stages of restrictive cardiomyopathy. You will see normal or small ventricles with massive atrial dilatation, disproportionate atrial dilatation, and this is called the ice cream cone appearance. That's a classic appearance for restrictive cardiomyopathy. Although you can also have an ice cream cone appearance in dilated cardiomyopathy to a lesser extent. Due to increased pressures in the ventricles, the atria often become enlarged as they try to compensate for the impaired ventricular filling. The ventricles in restrictive cardiomyopathy are usually not dilated, but may appear normal or slightly thicker. There's no significant ventricular enlargement, but the walls are rigid and less compliant. The exception is amyloidosis, which is a restrictive cardiomyopathy but has very thick walls. Mitral annular motion is markedly reduced in restrictive cardiomyopathy. In restricted cardiomyopathy, diastolic dysfunction is quite advanced. The LV size and systolic function can be normal, but you will see elevated LA pressure and elevated LVEDP. The LA volume index will definitely exceed 35 millimeters per meter square. The E to A ratio will exceed 2. You will have decreased mitral annular tissue Doppler velocity on both the septal and lateral sides. You'll have an elevated E to E prime ratio above 11, and pulmonary vein systolic and to diastolic velocity ratio of less than 0.5. You'll notice that a lot of things that I just told you here are measures of severe diastolic dysfunction, which you can read more about in the diastolic function and diastolic dysfunction episode. Deceleration time will be less than 160 milliseconds, and flow propagation velocity will be less than 50 meters per second. These are signs of restrictive cardiomyopathy on echo. Also, please definitely check out the episode on constrictive versus restrictive disease for additional review on echo features to watch out for restrictive disease. There are not so many specially named restrictive cardiomyopathies as there are hypertrophic and dilated cardiomyopathies. So please refer to episodes in the general heart failure section for more details about restrictive cardiomyopathies in general. During the rest of our time in this episode, I'll focus on amyloidosis and hypereosinophilic syndrome, which are two examples of restrictive cardiomyopathies. Amyloid cardiomyopathy is the most common infiltrative cardiomyopathy. It is also the most common specific restrictive cardiomyopathy. There are several types of cardiac amyloidosis. There's AL, SSA, and ATTR. AL cardiac amyloidosis, which is primary cardiac amyloidosis, involves monoclonal immunoglobulin light chains from plasma cell disorders such as multiple myeloma. AL amyloidosis involves the heart 50% of the time and also involves the kidney, liver, soft tissue, nerves, and spleen. Median survival is 2 years. SSA cardiac amyloidosis, previously known as senile cardiac amyloidosis, occurs in 75-year-old individuals and higher. It involves wild-type transthyretin or TTR. This is a symptomatic accumulation of TTR associated with aging, SSA amyloidosis. SSA amyloidosis involves the heart 100% of the time and also has carpal tunnel syndrome. This is the only amyloidosis with no other organ involvement outside the heart, and median survival is 5 years. ATTR, which is hereditary or familial cardiac amyloidosis, involves mutant transthyretin. This involves the heart 100% of the time and also has carpal tunnel syndrome. Median survival is 2 years. This is the only hereditary cardiac amyloidosis. So again, SSA cardiac amyloidosis, which is this previously called senile cardiac and is in 75-year-olds or higher, involving wild type transthyretin. That one involves the heart 100% of the time and has carpal tunnel but has no other organ involvement outside the heart. Whereas ATTR amyloidosis, which is the one that's hereditary familial involving mutant transthyretin, involves the heart 100% of the time and also the carpal tunnel, and can also involve other organs. The median survival is much better for SSA amyloidosis. That's the one with the asymptomatic accumulation of TTR associated with aging in elderly individuals, compared to the prognosis of AL amyloidosis and ATTR amyloidosis, which are 2 years each instead of a median of 5 year survival. Other than AL, the other systemic amyloidosis is AA, secondary amyloidosis, involving serum amyloid A or SAA, which has renal dysfunction and spares the heart. So remember, AA amyloidosis has renal dysfunction and spares the heart. Median survival for that is 1 year. And there's also diabetic amyloidosis involving amylin, which is only found in the pancreas, and Alzheimer's amyloidosis, which involves beta amyloid protein accumulation found only in the brain. Let's talk about presentation of amyloidosis. Other than carpal tunnel syndrome and peripheral neuropathy, other signs of ATTR deposition are lumbar spinal stenosis and, quote, self-curing hypertension, i.e., hypertension no longer requiring pharmacologic control. ATTR amyloidosis will also have weight loss, diarrhea or constipation, and orthostatic hypotension due to the autonomic neuropathy and peripheral neuropathy. The neuropathy and sarcoidosis is more cranial, involving facial and optic areas, whereas the neuropathy in amyloidosis is more peripheral. Only 45% of patients with cardiac amyloidosis will have low ECG voltage out of proportion to wall thickness, so you can't necessarily rely on that to rule it out. Other than low voltages on limb leads out of proportion to wall thickness, ECG of amyloidosis can also have a pseudo-infarct pattern of the anterior and or inferior regions. Congo red staining is used to evaluate histology of cardiac amyloidosis. In terms of imaging, classic PYP scan, the nuclear scan, only rules out TTR amyloidosis. That's the one that involves the heart 100% of the time. You still need to do blood work to rule out AL amyloidosis. That's the one that involves the heart 50% of the time. Serum kappa and lambda light chain measurement, AL measurement, and serum and urine protein immunofixation have supplanted serum protein electrophoresis for screening of AL amyloid. Let's visit the specific wording about this in the 2022 heart failure guidelines. Patients for whom there is a clinical suspicion for cardiac amyloidosis should have screening for serum and urine monoclonal light chains with serum and urine immunofixation electrophoresis and serum-free light chains. That's a class 1 recommendation. In patients with high clinical suspicion for cardiac amyloidosis without evidence of serum or urine monoclonal light chains, bone scintigraphy should be performed to confirm the presence of transthyretin cardiac amyloidosis, class 1. In patients for whom a diagnosis of transthyretin cardiac amyloidosis is made, genetic testing with TTR gene sequencing is recommended to differentiate hereditary variant from wild-type transthyretin cardiac amyloidosis. Echo features of amyloidosis are preservation of apex contractility compared to basal segments, increase in LV wall thickness, yet EKG showing low voltage in the limb leads, voltage mass discordance, ground glass sparkling characters of the myocardium. Remember, ground glass sparkling myocardium is amyloidosis, not sarcoidosis. Biatrial enlargement in the ice cream cone shape, thickening of the valves, thickening of the interatrial septum, plus or minus pericardial and pleural effusion. There is a direct relationship between LV wall thickness and mortality in amyloidosis. Typically, when LV wall thickness exceeds 15 millimeters and starts to climb, you have higher mortality in amyloidosis. Other factors that are associated with worse survival in amyloidosis on imaging are short mitral deceleration time, less than 150 milliseconds, increased big E to A ratio and big E to small e prime ratio, increased left atrial volume, abnormal tie index, LV and RV dysfunction, RV enlargement, pulmonary hypertension, and less negative strain. LV cavity size remains remarkably normal in amyloidosis and does not give prognostic information. Although LV ejection fraction may appear normal in patients with symptomatic cardiac amyloidosis, systolic dysfunction is often present. Nevertheless, if you do strain imaging or speckle tracking, that will reveal reduced longitudinal strain at the LV base but preserved apical strain. That is what we call the classic cherry on top sign. The finding of pericardial effusion is common in amyloidosis and does not give prognostic information or have clinical significance. But the presence of pleural effusion carries negative prognosis. Cardiac MRI of amyloidosis will show diffuse subendocardial gadolinium enhancement. What should we know about management of amyloidosis? It's interesting because now we have new medications for TTR. Transthyretin is a tetrameric transport protein produced in the liver that normally carries thyroxine and retinol binding protein, which carries vitamin A. In TTR amyloidosis, mutations in the TTR gene or age related changes cause TTR tetramers to dissociate into monomers, which misfold and aggregate into amyloid fibrils, which deposit into the heart and nerves. Tafamidis is a protein chaperone that binds selectively to the thyroxine binding sites of transthyretin tetramers, stabilizing the tetrameric structure and preventing it from dissociating into misfolded transthyretin monomers, reducing subsequent amyloid fibril formation. Patisiran is a small interfering RNA that silences hepatic production of transthyretin protein. Tafamidis improves all-cause mortality in both hereditary TTR amyloidosis and wild-type TTR amyloidosis, but this requires prolonged use, and patients with New York Heart Association 4 symptoms were excluded from the study. Tafamidis attenuates worsening of heart failure symptoms and exercise symptoms, but does not improve these symptoms from baseline. Patisiran is only approved for familial amyloid neuropathy. The 2022 heart failure guidelines offer one recommendation about management of amyloidosis. In select patients with wild type or variant transthyretin cardiac amyloidosis and New York Heart Association class 1 to 3 heart failure symptoms, transthyretin tetramer stabilizer therapy, tafamidis, is indicated to reduce cardiovascular morbidity and mortality. That has a class 1 recommendation. Now let's move on from amyloidosis to hypereosinophilic syndrome. Hypereosinophilic syndrome is a restrictive cardiomyopathy. It is defined as hypereosinophilia, which is absolute neutrophil count of more than 1.5 10 to the power of 9 per liter on at least 2 occasions with an interval of at least 1 month, or histologically proven eosinophilia in tissues. For example, bone marrow aspiration with at least 20% eosinophils or histologically proven tissue infiltration. Also, you should have eosinophil mediated organ dysfunction and or damage and no other identifiable etiology for the eosinophilia. Non-cardiac manifestations of hypereosinophilic syndrome are stroke, TIA, pulmonary emboli, easy bruising, frequent sinus infections, vasculitis, diarrhea, vomiting, nausea, hepatosplenomegaly, arthralgia, arthritis, Raynaud's phenomenon, retinal abnormalities causing visual disturbances, and migraines. Hypereosinophilic syndrome's cardiac manifestations have 3 stages: an acute necrotic stage, a thrombotic stage, and a fibrotic stage. The acute necrotic stage, which lasts 6 weeks, consists of eosinophilic infiltration of the subendocardium and myocardium of both ventricles, frequently asymptomatic. The acute necrotic stage can have an acute necrotizing myocarditis that sometimes mimics acute coronary syndrome. Then you have the thrombotic stage, which lasts 10 weeks, in which there's mural thrombus formation, LV much more so than RV, or both, with possible embolism, pulmonary or systemic. There can be valvular or subvalvular thickening or tethering with fibrothrombotic material and atrioventricular valve regurgitation. Lastly, you can have a fibrotic stage, which lasts 24 months and can be chronic, in which restrictive disease develops. There may be entrapment or rupture of the chordae tendineae, fibrosis of the apical and trabecular endocardium, and atrioventricular valve regurgitation. Heart failure can develop in either the thrombotic stage or the fibrotic stage, which is the second or the third stage. If hypereosinophilic syndrome is treated prior to the fibrotic stage, reversibility is still possible. How about imaging? Echo findings of hypereosinophilic syndrome are apical thromboobliteration of the left ventricle, usually, sometimes of the right ventricle, with endocardial thickening. This can get mistaken as an apical LV thrombus of ischemic heart disease, but in ischemic heart disease, there should be akinesis of the corresponding wall, whereas the wall motion remains normal or at most hypokinetic in the apex of hypereosinophilic syndrome. You can also have Merlon sign, which is a hypercontractile basal segment. Another feature is diastolic dysfunction with restrictive filling pattern. Of course, you'll see that one in pretty much any kind of restrictive cardiomyopathy. Another feature, which is quite classic for hypereosinophilic syndrome, is subvalvular thrombosis, causing entrapment of the mitral valve, usually the mitral valve, sometimes the tricuspid valve, entrapment of the leaflets causing mitral regurgitation or tricuspid regurgitation. The LV function and size are remarkably preserved in hypereosinophilic syndrome, which is consistent with the general trend in restrictive cardiomyopathy for the LV function and size to be remarkably preserved or just mildly affected, at least in the initial stages of disease. In terms of management, therapy for hypereosinophilic syndrome includes corticosteroids, hydroxyurea, interferon, heart failure GDMT, and palliative surgery. That's all for restrictive cardiomyopathies.
This podcast is intended for qualified healthcare professionals and is designed for training purposes only. These materials should not be used for direct patient care or as a substitute for independent clinical judgment. For more educational content or to submit suggestions, visit www.rehu.com/meded.